everyone, welcome to the RSCP High Yield Concepts in Radiology. My name is Kishan Patel, and today we'll be talking about ETT placement and complications. To start, an ETT is an endotracheal tube, and it's a small plastic tube that's put into a patient's airway to allow for ventilation. They're used to establish an airway to help patients breathe when they can't for themselves during surgery, respiratory failure, airway compromise, and more. For further context, an ET tube is typically placed using a laryngoscope or blade to help better visualize a patient's airway for placement of the tube into the trachea. There are multiple methods to confirm proper placement in the trachea, including listening for bilateral breath sounds and looking for equal chest rise to make sure both the lungs are being ventilated, measuring end-tidal CO2 to make sure we're getting carbon dioxide back from the lungs through the tube, and imaging methods to ensure placement in the proper area. The two main imaging modalities to confirm placement of an ET tube are chest X-ray and ultrasound. Chest X-ray is by far the most common and easiest, so we'll focus on that. It's helpful to have an ordered manner of checking a chest X-ray for proper placement, so I think this is a helpful scheme for me. First, we can note the patient's lungs for proper filling and/or note any deformities or defects. Then we can next note the location of the carina, which is the point where the trachea splits into the right and left mainstem bronchi, as shown by this bottom arrow here. And then we can find the ET tube tip, which is this little bevel point right here that you can find by tracing down this line, as noted in this circle. Ultrasound is another imaging option to confirm placement, but it's not as frequently used. The key anatomical point to help us differentiate between a tracheal intubation and an esophageal intubation are the cartilaginous rings around the trachea help keeping it patent, whereas the esophagus can collapse unless it's filled. On the ultrasound, you'll note a proper tracheal intubation if there's only one air mucosal or AM interface with reverberation artifact and posterior shadowing noticed, as you can see in this image here. An esophageal intubation will be identified if there are two AM interfaces with posterior shadowing, as noted in this image here, otherwise known as a double-tracked sign. Now let's talk about some complications of ET tube placement and how to identify them. First, we have a mainstem intubation, which is when the ET tube is placed into one of the mainstem bronchi or directly on the carina, leading to ventilation of only one lung. On this first chest X-ray, we have an adult patient. If we think back to our scheme of checking lungs first, you can immediately see a partial collapse of the left lung here. It's not being properly filled up. Next, we can identify where the carina is, which is highlighted here. And next, we can find the ET tube tip, which is circled here. As we can see, the ET tube tip has been advanced too far directly into the right main stem. We can resolve this by pulling back on the ET tube and getting repeat imaging. Now here we can immediately see some resolution of that prior left lung collapse. After identifying the carina highlighted here, and the location of the ET tube tip circled here, we can see that the ET tube tip has now properly been placed above the carina. Now we have a similar case this time in a pediatric patient. Immediately looking at this first chest X-ray, we can see that the left lung and right upper lobe have collapsed after ET tube placement. We can next identify the carina highlighted here, and the ET tube tip circled here. And note that the ET tube tip has this time again been advanced too far into the right mainstem bronchus, and likely into the bronchus intermedius, leading to the right upper lobe collapse. After retracting the tube and getting repeat imaging, we can see resolution of the left lung and right upper lobe collapse. Now identifying the carina here, and the ET tube tip here, we can see that the ET tube is properly placed above the carina, allowing for proper ventilation and lung filling. The next complication we have is an esophageal intubation. Looking back at how I mentioned how an ET tube is placed using a laryngoscope or blade, note in the figure that the esophagus is immediately posterior to the trachea, and how an ET tube can easily be placed into the esophagus instead of the trachea if the airway is not properly visualized or if the patient has certain confounding comorbidities such as increased body habitus. The ET tube will then end up in the esophagus and can cause oxygen to be pumped into the stomach instead of the lungs. Now looking at this chest X-ray, you'll notice that this red arrow indicates the tip of the ET tube, which overlies the midline mediastinum just inferior to the carina. Next, these yellow arrows show gaseous distension of the lower esophagus, and finally this green arrow shows gaseous distension in the stomach. Along with the low lung volumes and areas of atelectasis bilaterally, these findings help us confirm an esophageal intubation. Another complication we can have is pneumothorax. The introduction of a tube down a patient's airway also introduces the risk of iatrogenic trauma. As you can see in this chest x-ray of an intubated infant, we have signs of pulmonary interstitial emphysema and right-sided pneumothorax in these areas here. The last complication that we will be discussing is subglottic stenosis, or narrowing of the airway below the vocal cords and above the trachea. As you can see in this chest x-ray, the abnormally high placement of the endotracheal tube results in balloon inflation at the level of the larynx. This increases the risk for laryngeal injury, and some patients can have abnormal phonation after extubation and may develop subglottic stenosis, as you can see on the sagittal and 3D reformatted CT images to the right, and with the red arrows indicating the areas of subglottic stenosis. These are my references, and I want to give a special thanks to Dr. Kevin Hyatt for the images and guidance.